Santander, un paraíso abrazado por la majestuosidad del cañón del Chicamocha. Cuna de la libertad de América, corazón de Colombia y orgullo de miles de santanderianos soñadores y trabajadores que enaltecen la grandeza de nuestro departamento. Aquí, hace 6 años nació Acome Santander, una organización de estudiantes de medicina de la UIS UNAV-UDES que juntos trabajan por dejar huella y construir un país mejor.
En Acome Santander formamos líderes que luchen por un bien común.
En Acome Santander llegamos a todos los rincones de Colombia, llevando un mensaje de esperanza y bienestar.
En Acome Santander nos caracteriza la alegría y el deseo de triunfar como equipo.
En Acome Santander nos representa la unión y el trabajo en equipo.
En Acome Santander promovemos la salud y el deporte.
En Acome Santander repartimos sonrisas y dejamos huella en la población.
En Acome Santander somos parte de la aventura de nuestro departamento.
En Acome Santander nos une el respeto, la empatía y las ganas de crecer juntos.
En Acome Santander nos conectamos con el medio ambiente para preservar la vida.
En Acome Santander somos una familia que permanece unida, sin importar el tiempo ni la distancia.
En Acome Santander luchamos por nuestros derechos y por un sistema de salud digno para todos los colombianos.
En Acome Santander innovamos y le abrimos un espacio a la academia y a la investigación.
En Acome Santander enseñamos y aprendemos juntos.
En Acome Santander levantamos la voz por aquellos que no tienen la oportunidad de hacerlo.
En Acome Santander somos médicos más allá de los consultorios.
Acome Santander, sé parte del cambio.
Acome Capítulo Santander se siente afortunado de contar con más de 400 miembros que con orgullo hacen parte de la gran familia de Corazón Azul. Nos brinda alegría hacer parte de la formación de médicos cuya labor va más allá de los consultorios. No es suficiente con ser buen médico, sino excelentes personas. Desde cada corazón henchido de orgullo en este capítulo, deseamos feliz cumpleaños a la Asociación Colombiana Médica Estudiantil.
Good evening, everyone, and welcome to this first Acome and LAUGHH Foundation Academy update. My name is Juan Pablo Maldonado. I'm a medical student member of Acome, which is the acronym for Colombian Medical Students Association. And I'll be joining you tonight as a host. First of all, I'd like to thank Acome and the LAUGHH Foundation for the initiative to create this event. Also, I'd like to mention our sponsors that are making this incredible event possible: LCSM, Student Network Organization, Panamericana, Elsevier, Grupo CTO, Expedientes Médicos, GeoAsesores, Focus Your Mind, y Cardio EKG. Thank you all for your support. Tonight we'll be having 2 lectures, how to build teams in emergency departments and updates in wound management. We would like to remind you the steps to obtain the certificate. So first of all, you must fill the registration form at the end of the talks. You must fill the attendance form, and it's important that you know that it's going to be only available for 1 hour. You must complete the attendance form, and you must have a keyword that we will display during the presentation like this, in the lower part of the screen. And you have to remember that you must attend at least to 7 of the 9 days of talks to get your certificate. So now for our first talk, we will have Dr. Bruce Sands. Dr. Sands is a fellow of the American College of Emergency Physicians. He has practiced emergency medicine for more than 30 years, with most of the time spent at Level 2 Trauma Center, in which he treated many of blunt and penetrating trauma patients. During his career, he was involved in teaching advanced cardiac, life support, and pediatrician advanced life support courses. He served as the co-medical director of the LAUGHH Foundation. Welcome, Dr. Sands.
Two trauma centers. I trained at a Level 1. Spent most of my career in the Level 1. Most of my career at a Level 2, and then later in my career, when I did moonlighting, I would moonlight in some of the smaller emergency rooms. Now, the reason we use teams to treat patients in the emergency department is when we have critical and emergent patients in the emergency department, we need to expedite their care. So the best way for us to do that is to form teams so that we can approach a patient in an organized and fast manner. Before I begin, I'd like to go over a short history. Okay, I'm getting a message that there's some issues with my presentation showing up.
Yeah, I got a link.
Okay, let me see if I can go in here and correct this. Can you say anything now? No. Okay.
Hold on. Oh, you're on. You're on.
Okay.
It's good. Go ahead.
All right. Let me go back here a little bit. So the primary. Let's go back to 2. Okay. Short history of emergency medicine in the U.S. Okay, for comparison, internal medicine has been a specialty since 1936, and surgery has been a specialty since 1937. The American Board of Emergency Medicine was formed in 1976, and they had their first certifying exam in 1980. To give you a reference to my involvement, I graduated from medical school in 1978. In 1979, I did my internship in flexible surgery, and I also moonlighted in the emergency room since I was a licensed physician. I did a little research on Colombia. Colombia recognized emergency medicine as a specialty in 2005. In 2017, there were 7 residency programs based on the information that I've obtained. So it appears that emergency medicine now has 40 years under its belt. And during our early years, I'd say the first 20 years, a lot of the people practicing in the United States were actually in other specialties and or general practice, and they were becoming certified in emergency medicine through the practice option, which was practicing, continuing medical education over a 5-year plus period and sitting for their written and oral examinations to become board certified, and then recertifying every 10 years. Emergency medicine, our primary focus is to care for critical and emergent patients, but we treat all patients that present to the emergency room. And keep in mind that emergency medicine is a team sport. It's dependent on everyone being part of the team. If you play football, think of yourself as the quarterback. If you're a person who plays foosball, think of, okay, I'm getting another message that there's an issue. Okay, still not showing. Okay. All right, let me hold on for just a second. I'm gonna have to go out and see if I can see what's going on here. Stream here. Switching to apologize. So, and there should be a handout of all the slides. There's a PowerPoint presentation that I converted to a PDF, so hopefully you have that to view as well as the screen. So the primary focus of emergency medicine is critical care and urgent patients. Like I said, it's a team sport. Think of yourself as the team leader, and you have to know the skills of all the members within your team, and you want to promote learning. And the best way to promote learning is to actually be involved in the teaching process. And once your team members display competencies, you should allow them to run with it. Sort of like what we do in medicine: learn, do, teach. Okay. So what are the components of teams in emergency medicine? There's basically 2 components. You have the clinical training, and embedded within that clinical training is team training, how to set up your teams. So the first training that needs to be done is for your triage nurse. Your triage nurse is the person who It's the nurse who first sees your patient when they enter the emergency room. And the ESI, Emergency Severity Index, was started in 1998 by Dr. Wirtz and Dr. Ettel. Unfortunately, Dr. Wirtz died in 2000 of an aortic rupture, and his work was continued by his partner Ettel. And then there were three doctors of nursing who were also involved, and they are still involved in the ESI index. And I've included a copy of the 2020 manual from the ESI website of the Nursing Association. So that's part of your handout. It goes over the whole ESI, but it's good to take the course. It's a 4-hour course in itself, but it shows how patients are stratified from the critical to the non-critical. It's a 5-level system, and the most severe patients are level 1 and level 2, and those will be the patients we will talk about managing today using team approach. The Advanced Cardiac Life Support course is another course that is very useful for treating cardiac patients. It takes you through all the scenarios, medications, treatments, use of defibrillation, use of cardioversion, intubation. So it's good to take that course. It's a 12-hour course, as well as the PALS course, because, well, pediatric patients aren't as likely to need emergency care. When they do, they're not little children, so it's important to have the skill sets that are necessary for pediatric care. And last but not least, advanced trauma life support is for treating trauma patients. And trauma patients are the ones that are most labor intense and most skill intense. In terms of team training and team design, the design is pretty stable. Like for resuscitation team, you need someone to control the airway. You're going to need someone to do compressions. You're going to need someone to manage the monitors, someone to start IV and give IV medications, and somebody to record what's going on. So that's 6 people. But if you only have 3, what's going to happen is you're going to have to double up some of the roles. So you start with the basic framework and then you assign the skills. One thing I found worked the best is when I was assigning skills, I would ask people what would they like to do. So if a nurse can do all of the skills, I would ask people to volunteer, because if you have an interest in something, you're going to tend to excel in it. So if you have an interest in airway, excel in that. If you have an interest in drugs based on the protocols, I will let that person handle that. Then once I see that everybody feels comfortable in theirs, then I would start rotating people to different skill sets so that they could build up their repertoire across all the 6 different role assignments, so that they can easily step in to fill someone else's role if they're not there or something happens. Leadership is very important. You have to be a good leader. A good leader has good communication skills. They're a good listener. They watch and see who's having difficulty. If someone's having difficulty, you help them out. You encourage people. You try to encourage people when they do something right. And if something's not right, then you lead them in the right direction. And then away from the team, you may want to talk to somebody if something was totally inappropriate. while you're doing the codes, you would say, no, let's do this instead. And then after the code's over, take them aside and say, hey, why did you do this? And here's why this wouldn't be appropriate, or this might be dangerous at this point in time. Communication, when you're doing a code, you want to make sure the person that you ask to do something understands what that communication is, so they should read it back to you. So if you tell the nurse to give 6 milligrams of adenosine IV push with a flush immediately afterwards, she'll read back to you, drawing up 6 milligrams of adenosine with normal saline flush after push. So you got that closed loop, and then after she's delivered it, she'll say 6 milligrams of adenosine delivered, and the recorder will mark the time that was completed. And mock practices and debriefings are very important because practice makes perfect. If you were on a football team or a football team, you would practice. Same thing with this. You want to practice your skills, practice your skills. And if you're lucky, you've got the fancy equipment, you can have the monitors that are set up to a signal generator that can generate on the screen, VTAC, VFib, atrial tachycardia, supraventricular tachycardia. If not, what you do is you just get some of those strips, have one of the doctors or nurses serve as the patient, and you build scenarios. So if I'm the patient, I say, I'm unresponsive. So you say, okay, look at the quick look paddles. What do I see? And then you hand them that strip. And then they should say if it's a ventricular tachycardia that you're going to cardiovert. So doing those kind of mock practices is the way you develop the skills to be able to play on the playing field. Without practice, you're not going to get better. Practice makes perfect. Okay, so let's talk about ESI, Emergency Severity Index. Okay. ESI level 1, I call it critical patient. The ESI actually calls it resuscitation. And I've just in my mind, I've always used critical because some of the patients you're going to get to just before they actually need resuscitation. I mean, like when I say just before, like seconds or maybe a couple of minutes, that you can intervene so that you're not doing a full-blown code. And who are these patients? Who are these patients that need immediate life-saving interventions? These are patients with severe respiratory distress. They have oxygen saturations of less than 90, partially obstructed airways, person who has a pulse rate or rhythm that's concerning to you. Do they have peripheral cyanosis? Do they have modeling? Have they had acute change in mental status? Have they gone from alert, verbal to now they're only responding to painful or unresponsive? And last but not least is that initial impression. I think most of you heard of this term gestalt, that gut feeling. And that gut feeling is sometimes based on your years of experience. I've worked with many triage nurses to just say, this patient needs to come back and get right on. And keep in mind, once you determine a patient is level 1, you don't have to do any more evaluation. You bring them back. So you're going through a list, but if there's something there that says this is a level 1, this person needs to be resuscitated, then that person comes right back. Now, our ESI level 2 patient is an emergent patient. And this is a patient who shouldn't wait. So see the fine distinction? Shouldn't wait, can't wait. So someone who shouldn't wait may have to wait because you're dealing with a critical patient. and you would move them along appropriately. So who are these patients? Patients with high-risk symptoms, situations, something suggestive that they can deteriorate. So the person with substernal chest pain, the person who suddenly can't get their words out, weakness to an arm or leg, acute confusion, severe pain, pain 7 out of 10 or greater, especially if they're diaphoretic. And keep in mind that not everyone who gives a rating of severe pain of 7 or greater is really a level 2. I've had patients say that their pain is a 9, they're having abdominal pain, and they're eating chips. So you know that this patient is not a level 2 patient. Some of these patients can just be treated with some interventions at triage, someone a hister, some with a hammer. Okay? Their pain is a 9 or 10 out of 10. But what you have to do is treat them, give them ice, give them oral analgesics, and then go from there. Okay, so what should our resuscitation room look like? Okay. Resuscitation room should look something like this. You have the bed that the patient is on. To the right, I don't know if this is transposed, but there's a cart with blue handles on it. And that's on your, to me, it's on the right, but I remember in this system, it might get transposed to the left. But that cart is a crash cart. On that crash cart, you notice there's a monitor, and that monitor also has the capacity to defibrillate a patient. You can either use the quick look paddles or you can use the pads. So if you've got someone who's level 1, I would put them on that to begin with so that they can monitor them. And if you need to give them a shock right away, you're all set up. If you've got the pads on that can deliver a shock, then all you got to do is set your jewels and you're ready to go. Also within that cart, you're going to have your trays for doing cricothyrotomy, for putting in a central line, all the ACLS drugs, your lidocaine, your epinephrine, your atropine, etc., and so forth. You notice on the bottom of that cart on the end is a suction. That is a low vacuum suction. Anytime you can use a wall suction, as you notice to the left of the bed or on the other side of the bed, that canister, that is a better suction. You get better suction, you can clear airway faster. So I'd only use the small suction as a last resort. And you have the regular monitor on above that canister, which has all your different pulse ox and everything, your blood pressure. Some of the little tricks of the trade for the team is keep 2 IV bags hanging. Don't open them, just hang them on your IV pole right there. What we would do is tape the infusion set onto the bag and tape the catheters as well onto the bag. So you 18 gauge catheter or larger. So when you got a patient, you're not fumbling around to get those things. You just grab the IV bag off, you pull off your infusion set, your catheter, slip your catheter in, put the 20 cc syringes, take those to the pole, pull those off, and you're ready to go. Same thing with your monitor. Put the leads for the monitor, put the sticky pads on. So when you're ready to put them on, all you have to do is peel off the cover over the sticky and put it on the patient. Okay. So let me just go back here for a second. Just give you a little simple scenario. Patient comes in to triage. He says he's not feeling well. You notice he's a little unsteady on his feet. And the triage nurse immediately places him in a wheelchair and she brings him back. She says, I've got a level 1 patient. So in this setting, we only have 2 nurses in the ER, and the 1 doctor covers the ER as well as the floor. So the triage nurse brings back the patient. She puts him on the bed. The first nurse establishes an IV, draws some blood, and just as she's finishing that, the patient becomes unresponsive. So she quickly checks for a pulse. She has a good pulse, so she hears a low gurgling. She suctions the airway and starts bagging the patient. The second nurse is called the doctor who was on the floor, so he's on his way down, and she assists with getting the patient on the monitor. So just as the patient arrives, just as the doctor arrives, I should say, the doctor grabs the intubation tray and he's setting up to do an intubation when the nurse calls out that the AccuCheck is 38. So the nurse pushes an amp of D50W. 20 seconds later, the patient awakens. And that's a simple scenario where you have a team approach. You have 2 nurses working in concert. Each one knows what to do, how to switch roles back and forth as a patient changes. So if you're in a teaching setting, you probably have a setup somewhat like this. You'll have an attending physician at the foot of the bed. You'll have the, running the code that day at the foot of the bed. You'll have a respiratory therapist at the head of the bed. One nurse will be the crash cart. You'll have a nurse or others doing compressions. And you'll have another nurse who will be doing your recording. And if you've got another doctor there, that doctor may be doing procedures. So you may have to put in a central line because you can't get in a peripheral line, or you may put in an intraosseous. So the more people you have, the more you can spread out your team. And the less people you have, the more you have to share roles. Okay. So for a simple team, say most times you're going to have 2 nurses to work with when you're doing a code or start a code or dealing with a patient. So what you would do at that point is you would have the first nurse establish the IV, draw blood, central labs, do an AccuCheck. The second nurse would place the patient on oxygen, cardiac monitor, also to get blood pressure. And the patient would rapidly assess the patient. And like that short vignette that I provided, if people are out of place, then you have to go to basics. So 1 person resuscitation is chest compression, and every 2 minutes you give 2 breaths. So as people come in, you gotta shift those roles. And that's one of the things you want to make sure you practice is those shifts so that people can do those seamlessly. So at first it's going to be awkward, but as you practice, it'll become easier and easier. So what are the tasks you're going to do for that level 1 and level 2 patients? Usually we bring them in, put them on oxygen, get vascular access, hook them up to monitors. If medications are needed, we'll give those. The blood that was drawn is sent to the lab, get the AccuCheck. Arterial blood gases, what we would do is sometimes I would draw arterial blood gas. If respiratory was there, they'll draw the arterial blood gas. Call for EKG. The patient's stable enough, or once you get the patient stable, then you consider doing CAT scans, ultrasonography at bedside. If you got an ultrasonographer in your hospital, or he may be on call, or she may be on call, you may have to call them in. For the young doctors, I would say if you can do an ultrasound course, do a multi-day ultrasound course and know it inside out. There's so much utility to being able to use an ultrasound in the ER. So the resuscitation team are straightforward. I assume most of you had ACLS. If not, I would try to take an ACLS course or review an ACLS course because it goes through the whole system. But basically, you're going to have a team leader who should be someone trained in ACLS or familiar with ACLS, a physician or a nurse. Now, you may be like we were years ago, only physicians could lead the team. Now, nurses are, and mid-levels are leading teams. Respiratory would be respiratory therapist or a nurse, someone to do compressions, someone to provide vascular access, someone to handle the monitors, and someone to do the recordings. So again, 6 people, you've got to make adjustments and be able to do these on the fly. So let's talk about the trauma team for a non-trauma center. The trauma leader, you're going to want to have someone who ideally has had ATLS training or the equivalent training. It's going to be a physician. In addition to the team leader, you want to have a primary physician who's going to perform your primary and your secondary survey. You want to have an airway team who will manage the airway and has airway management skills. You'll have hopefully 2 or more trauma nurses who will be in charge of the monitors, IV access, and collecting the patient's clothes, cataloging their personal items. And the recorder is usually going to be a nurse as well. One of the things that I provided for you is I created a generic trauma flow sheet that's in the package that I sent. And I sent in 2 formats. It's PDF and a Word document. The reason I gave it to you in a Word document so you can alter it to meet your needs. I tried to cover everything, and then you can go in and make any adjustments you want to make. X-ray technician, we would, some hospitals at the X-ray department is close to the ER, you just have the secretary call the X-ray technician to come over. And ultrasound technician or the physician trained in using ultrasound. Again, extremely helpful ultrasound in trauma. I would encourage everyone to get the ATLS 10, which came out last year, and review that. If you can't take the course, at least get the manual and read through it. And then 2 of the references I gave were to 2 courses that they don't give you the whole course, they just review for testing purposes the major changes that have occurred since the latest edition came out. There's been some changes to how things are approached and how some things are done. Some of the new guidelines are 1,000 milliliters of normal saline. And if that doesn't restore blood pressure in trauma case, you should go to blood under the direction of the team leader. And there's also a recommendation of tranexamic acid being given, but it has to be given within 3 hours of injury, not arrival in the emergency room. So you have to make sure you can get the exact time of the injury. If it was something like an earthquake, you would go by what the geological survey said the earthquake occurred if you don't have any other time frame. So you got to use all the resources you have to estimate the time of injury. And if you can't pin it down to less than 3 hours, you should stay away from tranexamic acid because it could create problems. So when the trauma patient arrives, just like we did with the critical patient, you immediately assess them. So in trauma, it's A, B, C, D, E. So first thing you do is you approach your patient. Mr. Smith, can you tell me what happened? If he's able to talk to you, you know that he's perfusing his brain. He's able to phonate. He's ventilating well enough and he's getting enough oxygen. So you still look at his airway, make sure there's no signs of trauma or anything that may change. If you see soot, there's a fire and there's soot in the nostrils, and you got to worry about swelling to the vocal cords and glottic areas. So patient may be able to talk to you initially, but if there's soot there, that's the person you got to plan on intubating sooner than later, because if there's swelling from the thermal, you can get a quick blocking of the airway. It may switch from an airway that you can intubate to an airway that you got to go to a cricothyrotomy. You want to check breathing and ventilation. Is the patient breathing greater than 8 times a minute? Person with a Glasgow coma score 8 or less needs intubation. Patient who's trying to phonate, trying to talk, and they can't get words. It's not words. There's some damage to the airway. Then you got to think of, again, an emergent airway, a cricothyrotomy. C is circulation. So after you check breathing, you listen to the lungs. You want to make sure there's no diminished breath sounds. You want to listen. You want to palpate to see if there's any subcutaneous emphysema, which would indicate there may be a trachea tear or a bronchial tear, which is an emergency. Circulation, you want to listen to the heart. In a busy, noisy ER, you may not be able to pick up muffled heart sounds, but you may see distended neck veins or other signs that there may be a pericardial effusion. You want to check pulses in all extremities. You want to control any hemorrhagic areas. And one thing I'll mention about hemorrhage is, to stop hemorrhage, you just have to have enough pressure, a millimeter above whatever the pressure is in that vessel. It's an arterial vessel, of course, it's going to be higher than a venous vessel, but it's proportional to the pressure put on that bleeding site. 1 millimeter above whatever that pressure is will stop the bleeding. And my pet peeve was always people who would come in with head injuries, and I would see these big bulky dressings on a person's head and take it down because it's soaked in blood, and I see a centimeter laceration that's bleeding. And what happened is the 4x4s that were placed on it and held down as tightly as possible was such a wide surface area that all they did was serve as a sponge to absorb all the blood. Whereas if you took a 2x2 and pushed it on that 1 centimeter bleeding site, it would stop. And the best analogy I used to always use when I was teaching is, if you were to lay your hand on the floor and I were to step on your hand, with my foot. I weigh 180 pounds. It would hurt, but it wouldn't hurt nearly as much as if a young lady who weighs 87 pounds stood on your hand with just the heel of her stiletto. Why? Because it's pounds per square inch. So the larger the area, the less pressure. So remember that when you're dressing wounds. If you got a small wound, don't put this huge dressing on it. Put a small dressing with pressure. Next thing, disability and neurological status. So is this person alert, verbal, responsive to pain, or unresponsive? Check the blood glucose, just like we did with the other patients. And you want to expose the patient. And keep in mind, you want to, once you disrobe the patient, it's not so much a problem in the warmer climates. In the colder climates, you want to prevent coagulopathy. So what you want to do is keep the patient warm, and always make sure the room is warm enough. If you're shivering, the patient is shivering. After the primary survey, you do a head-to-toe examination. If you haven't obtained it before, you want to get the ample history, which is the allergies, medications, past illnesses, pregnancies, last menstrual period, last meal, events, environments, mechanism of injury. So you just go through and do a rapid head-to-toe exam and neurological exam. So you're looking for everything and anything. And I'll refer you to the ATLS manual for how you do that. Once you read the ATLS manual, you'll be able to use that trauma flow sheet that I provided you with. So once you've done your primary and secondary survey, you're at a decision point. You've got a pretty good idea based on the mechanism of injury, based on your findings, what level of care this patient needs. And does this patient need to be transferred? So if you don't have blood, you don't have, say, a vascular surgeon or a neurological surgeon, and that's the patient you want to transfer then. And you don't want to delay transfer getting scans unless for some reason a trauma surgeon requested. I would never, in fact, I would be on the phone to the transferring trauma surgeon as soon as I finish my secondary survey, saying, this is what I've got, this is what I think is going on. I would like to transfer this patient to your facility. Again, adjustments are going to have to be made based on how you're practicing, what kind of environment, what kind of access to resources you have. So in conclusion, I just want to say that remember that emergency medicine is a team sport. You've got to support your team, you've got to build your team, and if you support them, they will support you. But to build your team around the resources available. What you got is what you got. I've had places where I've had more than team members than I need, and I've been in places where I've just had 2 people. And we all made it work. You want to become an expert in all aspects of emergency care. You want to be an expert at intubations, cricothyrotomies. That's one of the reasons I got involved in teaching the classes, so that I can be an expert and I can keep teaching other people in the process. So make sure you are good at all these central lines, how to insert those. You'll see, learn that in ATLS. Chest tube insertions, part of ATLS. Pericardiocentesis is also part of ATLS. So hopefully I've provided you with the basis for which you can go out and create your own teams. And again, there were many handouts that I provided. Hopefully they will help guide you. In closing, I would just like to mention one of the guiding principles that I learned from Dr. LaSalle Lafall. He was the head of the surgery department when I trained. He just died last year. One of the first things he taught us when we were on surgical rotation was equanimity under duress and keeping calm and cool under pressure. Maintain that degree of calmness and tranquility, because that will allow you to do the appropriate thing under any circumstances. And keep in mind, this was before there was emergency medicine. This is even more important for emergency medicine because emergency medicine is hours of boredom punctuated with minutes of sheer terror where you have to be relaxed and calm and just work through it. So with that, I will take any questions. Let me see if I can switch here and go back to my screen. Let's see how to do this.
Do you see your camera? You're turning it down. Is your camera there?
Okay, we apologize for the
my camera back up.
If anyone has any question, we are going to answer them now.
Can you see me?
No, we can't see you. So we have one question from Diana Ortiz. In addition to the excellent mentioned courses, what is the utility of the use of checklists for the care or, for the example, the trauma patient? Well, we're having some inconvenience with Bruce. So, Dr. Sands, we have one question. Can you hear me?
Okay, am I good? So are there any questions? I can't see questions. Okay, for some reason I can't, my camera is showing that it's on, but it's not displaying.
No, we can't see you. But we have one question.
I hear one. Let's see if I can switch out.
Okay. So here's your first question.
Well, unfortunately, we lost the connection with Dr. Sands, so we are going to continue. If we can maybe connect later, he is going to answer the questions you have. Next, we have Dr. Gann. So Dr. Gann is a Bachelor of Arts in Biology from the University of Texas at Austin. He is a Master in Medical Science of the American University of the Caribbean and a Doctor of Medicine of the American University of the Caribbean. So welcome, Dr. Gann.
Oh, thank you so much. I'm going to share my screen here. So hold on 1 second. Just a second. There we go. Hold on a second. It's not giving me permission to applications, Keynote. Okay. No. All right, I'm having some trouble. Can you guys still hear me? It's not letting me share. Share your entire screen. Share. Is it sharing? Can you guys hear me?
We can hear you, but it's not sharing the screen yet.
It's not sharing?
No.
Okay. Why don't, let me see if I can do this. Just a second.
There we go. You can see the screen.
Okay, I'm just gonna try to pull this up here this way. Can you see this?
Yes, we can.
We can see this? Okay. Everything's okay? So again, hi everyone. Sorry for the delay. First time using StreamYard. But anyway, my name is Marcus Gann. I am a general surgeon, and I've been working with LAUGHH and Acome for quite some time now. And when I go on the missions, I usually do wound management. So I've been asked to give just a. It is a huge topic, so I have sort of narrowed it down a little bit to 6 sort of basic topics.
We are looking at your Gmail. We are looking at your slides.
Dang it. Okay. Do you?
Santander, un paraíso abrazado por la majestuosidad del cañón del Chicamocha. Cuna de la libertad de América, corazón de Colombia y orgullo de miles de santanderianos soñadores y trabajadores que enaltecen la grandeza de nuestro departamento. Aquí, hace 6 años nació Acome Santander, una organización de estudiantes de medicina de la UIS UNAV-UDES que juntos trabajan por dejar huella y construir un país mejor.
En Acome Santander formamos líderes que luchen por un bien común.
En Acome Santander llegamos a todos los rincones de Colombia, llevando un mensaje de esperanza y bienestar.
En Acome Santander nos caracteriza la alegría y el deseo de triunfar como equipo.
En Acome Santander nos representa la unión y el trabajo en equipo.
En Acome Santander promovemos la salud y el deporte.
En Acome Santander repartimos sonrisas y dejamos huella en la población.
En Acome Santander somos parte de la aventura de nuestro departamento.
En Acome Santander nos une el respeto, la empatía y las ganas de crecer juntos.
En Acome Santander nos conectamos con el medio ambiente para preservar la vida.
En Acome Santander somos una familia que permanece unida, sin importar el tiempo ni la distancia.
En Acome Santander luchamos por nuestros derechos y por un sistema de salud digno para todos los colombianos.
En Acome Santander innovamos y le abrimos un espacio a la academia y a la investigación.
En Acome Santander enseñamos y aprendemos juntos.
En Acome Santander levantamos la voz por aquellos que no tienen la oportunidad de hacerlo.
En Acome Santander somos médicos más allá de los consultorios.
Acome Santander, sé parte del cambio.
Well, thank you. We're back, and now we can see your slides.
Okay, I'm gonna start it and then tell me if you can see it.
Okay.
Can you see the full thing?
Yeah.
Okay. All right. So, like I said, I'm a general surgeon. I work with LAUGHH and Acome. I usually do wound care on our medical missions, and I'm doing a quick, well, not so quick, but a quick update on wound care. So I divided up into 6 sort of major topics. So we're going to just do a brief review of the stages of wound healing, which I'm sure all of you guys already know. We're going to go over the goals and the basic principles of wound management, which can apply to all wounds. We're going to go over wound debridement, some topical therapies, the plethora of wound dressings that are out there, and then some of the advanced therapies. So just this is a schematic drawing of the stages of wound healing. So there's 4 main stages, as we all know. There's hemostasis, inflammation, proliferation, and remodeling or maturation. The components of the hemostasis stage is that usually happens immediately after injury. The small vessels will contract, the platelets will aggregate, the clotting cascade is triggered, and ultimately a fibrin matrix is formed. And then the second phase is immediately after that starts inflammation. So you have increased vascular permeability and cellular recruitment. This usually can go up to 3 days. And in chronic wounds, it can become arrested in this phase. So that's one of the problems we'll sort of address later on. The third stage is proliferation, which can be 3 days to 6 weeks. That's when all the cell types get activated. The fibroblasts start making collagen 3, type 3. The granulation tissue is made and replaces the fibrin, and then the extracellular matrix is deposited. And then the last phase is remodeling, which can be week 3 up to a year or even a little longer. That's when the collagen type 3 is converted to collagen type 1. You have increased tensile strength. So your wound will be at a maximum of about 80% of its original strength at about 6 weeks. Then you also will have wound contraction and repigmentation of the skin there. So the goals of wound healing. So these are the main goals. We want to repair the tissue in a timely manner. We want to restore the function and anatomy. We want to prevent infection. We want to minimize inflammation and edema. We want to minimize pain. And then we want to have the best possible aesthetic outcome for our patients. And then these basic principles can apply to any wound, whether you cut your finger while you're chopping onions or you have a chronic venous stasis ulcer. It applies to all wounds. So the first thing is we want to debride any necrotic tissue. We want to remove any excess wound exudate from the wound. We want to decrease the bioburden. We want to eliminate pressure on the wound. Especially for those decubitus ulcers and pressure ulcers. We want to control the edema and inflammation. We want to prevent infection, and we want the wound to close as quick as possible. So when we talk about wound debridement, there are a few different aspects to wound debridement. So wounds that have devitalized tissue, contamination, residual suture material from like maybe a dehiscence after a surgical procedure will require debridement. So in the acute wound, all these things that are in there will impede the body's attempt to by stimulating abnormal metalloproteases and consuming local resources necessary for healing. So it will slow down the healing, obviously. And then in chronic wounds, the devitalized tissue, the decreased angiogenesis, the hyperkeratotic tissue, the exudate, the biofilm, all that stuff prevent an adequate cellular response to wound healing stimuli that the body naturally sends to heal these wounds. And so you have this delayed healing of the wound. And then the majority of chronic wounds will require serial debridements. So the types of wound debridement, the easiest and the most basic is going to be irrigation. So that's going to decrease the bacterial load. It's going to remove any loose material. There's low pressure irrigation and high pressure irrigation. Anyone can do low pressure irrigation with a syringe and saline. So typically we use like a 30 cc or a 60 cc syringe. You can even put an IV catheter on the tip of the syringe to increase the pressure that you're getting, and you just irrigate with saline. The high pressure is going to mostly be done in the OR, and that is with a water pump that's battery operated, and it gives some really good debridement, but most of the time it's in the OR. It's really messy. So we use warm isotonic saline. And then there's no clinical evidence that any additives to the irrigant is going to help. So no antibiotics, no iodine, nothing, no betadine or hibiclins or any of that kind of stuff added to the irrigation is going to have any benefit. And some of those things actually may impede wound healing in the future. And then there's a newer type of irrigation where we use ultrasound in conjunction with irrigation, which gives better or more enhanced decrease of the bacterial load and just gives overall good, clean wound bed to put your dressing on. Now, surgical debridement, that's going to be the sharp excisional debridement. That's with the scalpel, scissors. You can scrape the wound, you can cut on the wound, but you want to remove all the devitalized tissue as possible and debris that's in the wound. It decreases the bacterial load. It stimulates contraction and wound epitheliation, so you get a little bit of bleeding, and it stimulates all those good things to start happening with the wound. Now, the enzymatic debridement, so you have exogenous enzymatic agents. One of the most popular one probably in the US is collagenase, and it eats away at some of this necrotic tissue and exudate, but it also can promote endothelial cell and keratinocyte migration, so it can help with wound healing as well. Now, enzymatic debridement is good for patients who are not surgical candidates or can't tolerate the sharp debridement at the bedside. So we use these enzymatic debridements. They take a little bit longer, obviously, but they're a good alternative. And then the one that everyone loves, the biologic debridement. So this is the maggot therapy. So it's the larvae of the Australian sheep blowfly or the green bottlefly. So the larvae secrete a proteolytic enzyme that liquefies necrotic tissue. It can be a bridge to surgical debridement, or you can use it in between debridements, or it can be used when surgical debridement is not available. The unfortunate aspect, it has a negative perception in patients as well as providers. They do sell, not in the US, but there are sort of dressings that have little bags that have the larvae in them, and you put them on the wound. It's all self-contained, so none of them get out or anything. But yeah, it has a negative perception, but it does do a good job. Now, there are some topical therapies we're going to talk about a little bit. Growth factors, they had their day in the past. They're not so popular now, but I think they're doing a lot of new research on new growth factors, but there were recombinant human growth factors. The three most popular ones are the platelet-derived growth factor, the epidermal growth factor, and then this granulocyte macrophage colony stimulating factor. So they have limited use, but they're actively being investigated, mostly in the treatment of chronic ulcers in the lower extremity, like venous stasis ulcers and such. And then antiseptics and antimicrobial agents. Some of them have some potential benefits in selected patients. You can use an iodine-based agent, a silver-based agent. You know, they kind of come in and out of fashion. Honey is an ancient therapy, so it has had a resurgence in the US, so we see a lot of dressings impregnated with honey, a lot of people using honey on wounds. And then the last one is a beta blocker. So keratinocytes have a beta adrenergic receptor, so there is a timolol ointment you can use that can help stimulate those cells. But again, not as popular nowadays. So when we're looking at dressings, what we want to do when we are choosing the best dressing, because there are hundreds and hundreds of dressings out on the market. So you kind of look at two sort of categories. One is what your goal is with putting the dressing on, and the other one is your patient considerations, like what the type of wound and the type of patient you have. So with the dressing goals, the main aspects are you want to eliminate the dead space, you want to control or absorb the exudate, you want to prevent buildup of biofilm and bacteria, obviously. You want to maintain adequate moisture, and we'll talk about moisture in a little bit, without macerating the wound edges, and you want to prevent leakage onto healthy tissues. Now, when you're looking at your patients, you want to make sure that the dressing is comfortable and it reduces their pain, that it's easy to put on and put off. It controls the odor, because sometimes that is a complaint with patients. And then depending on the device or the wound type of thing you put on, you want to make sure it's portable and it works with any orthotics that they have that's near the wound. You want to take into consideration the length of time that they're going to have the dressing, moisture as well, and then the cost. So let's talk a little bit about the perfect dressing. So this is in a perfect world. You want the dressing to conform to the wound shape and eliminate all dead space. You want it to be pain-free. You want it to remove exudate and contain the drainage. You want to make it easy to apply and remove. You want to make sure it prevents and removes all bacteria, debris in the necrotic tissue, and fibrinous slough. And it sounds perfect, doesn't it? You want it to be low cost and available everywhere. You want it to prevent maceration of the wound edges. You want it to not leave material behind or shred in a tunnel. You want it to not require frequent changes. You want it to provide compression where needed, and you want it to not cause dermatitis. Now, unfortunately, I don't want to hurt anyone's feelings or burst any bubbles, but the perfect dressing does not exist. There is no such thing as a perfect dressing that will work for every patient. There's always going to be a give and take on what you want to use, what you'll accept, and sometimes it involves using multiple dressings at the same time, or alternating between different ones. So essentially, there's not enough clinical evidence to guide us in choosing one dressing over another. And generally, what we do is the accepted consistency in different areas is based on what's available. So especially for anyone that's going to be working in a low resource setting, so you're just going to have to basically use what you have. And I'll give you some ideas and some low resource setting things that you can use as well. So let's talk a little bit about moisture. So moisture can be good, it can be bad. And it was once believed that wounds should be left exposed to the air. So I can't tell you how many times I've had people come to my office and say, oh yeah, I took the dressing off, I'm letting it air out, it's looking good, it's healing, and it has like a big scab on the wound. Well, in actuality, occluded or covered wounds will heal up to 40% more rapidly than non-occluded wounds. So I have to do a little patient education on wounds and dressings and sort of refocus them on keeping the dressing on their wounds. So an acute wound that has fluid, the fluid's going to be rich in all kinds of growth factors and a balance of metalloproteases, and it's going to be good for the wound. But then the opposite is in chronic wounds, the fluid contains persistently elevated inflammatory cytokines, which means that it can inhibit the proliferation of fibroblasts and collagen and all that stuff that we need. So it's kind of the inflammation is working against you. So in reality, with the wounds, you need the right balance of moisture to keep is basically the key. So you don't want too much, you don't want too little. You want just the right amount, just like the fairy tale. So some traditional therapies for dressing. So wet to dry dressing. So that's like the most basic. It's the cheapest. It's the most cost effective. The bad thing, the one downside is it requires frequent dressing changes. So basically the gauze, the wet gauze that has contact with the wound will debride the wound. It'll slowly debride the wound, and it takes a long time with wet to dry dressings. But you know, that some places that's all you have, that's all you can do. But the main thing is to keep it moist, clean, and covered. And then there's another dressing, the films, which we use a lot on the missions as well, and I'm sure you guys use them almost every day if you're in the hospitals right now. So it's a polymer film of transparent sheets of synthetic self-adhesive dressing. So it's permeable to gas and water, but it's larger molecules like bacteria and stuff like that won't get through. And also it's kind of known as, I mean, this is a ridiculous name, but it's synthetic adhesive moisture vapor permeable dressing. But essentially it looks like this. So I don't know if you guys can see to the dressing over the, looks like a fake wound, but anyway, it's on the guy's elbow. You can see the clear dressing. In the United States, we would call that like a Tegaderm, or like is like a brand name, but they're common. We use them over IVs. We use them all the time for all different kinds of dressings. And then the next sort of category is going to be foams. So foams are a layer of hydrophobic silicone or polyurethane based foam that lies against the wound surface, and it has a layer of hydrophobic gas permeable backing. So they're highly absorptive, and they conform to the wound. They're great for packing cavities. The foam is really a good dressing. It requires a secondary adhesive dressing to hold it in place. That's the one disadvantage. So you do have to have two dressings, basically. So these are some examples of foam. Some of these are kind of built in, so it has the adhesive dressing attached to the foam. You can also use the foam by itself, and then you put a different kind of adhesive dressing on top. These are just some examples that I found. And then the alginates. They are natural complex polysaccharides from various types of algae. When you put them in the wound, they form an amorphous gel that covers the wound. And when you can get alginates that have silver impregnated in them, and those sometimes will turn green or black when they're in the wound. So they're not appealing. And when the patient takes the dressing off, they get a little worried because it's black and green, but that's the silver tarnishing and turning it black. But anyway, this amorphous gel covers the wound, and it absorbs a lot of fluid, and they come in lots of different shapes and sizes and different absorptive capacities. They do require a secondary dressing, but they're very popular dressings. And this actually is a rope. So this is it's woven with thread to keep it, to make it strong, so you can pack it into cavities and tunnels and stuff like that, and then it'll form into a gel, and then when you pull it out, the thread that's holding it all together will keep it all together, and you'll be able to remove the whole thing. And then the next class is going to be the hydrocolloids. So this is a gel or a foam that's on a carrier of self-adhesive polyurethane film. So it traps exudate and creates a moist environment. So the bacteria and debris are trapped in the foam or gel as well, and they're removed when you remove the dressing. So it is somewhat of a debridative. It does debride the wound a little bit. And now the bad side is they can be a little malodorous. They don't smell necessarily the greatest, and they may need daily changes depending on the amount of exudate that's coming off the wound. So this is sort of an example of one that they're putting onto the shin there. And they are, like in the United States, a very common one is Duoderm. They have different, there's all different kinds are on the market, but they can be protective as well as absorptive there. So the next class is going to be the hydrogels. So that's a matrix of various synthetic polymers with greater than 95% water. It can come in sheets, gels, foams, any combination of anything like that. They absorb or donate water depending on the hydration status of the tissue. So they give and take, and to create that sort of level playing field with the moisture. And they sometimes need a secondary dressing depending on the configuration of the original dressing, whether it has it built in or not. So this is an example of hydrogel with a secondary dressing. So you can see the film dressing on top of that, and those can stay in place for a while till a few days, then you remove it and replace it. So this the next sort of class is the hydroconductive. So this combines two absorbent cross-action structures that facilitate movement of large volume of drainage and wound debris. So this is when you have tons and tons of drainage and you need something to absorb that. So this, the way this material is constructed, it actually pulls fluid out by capillary action as well as this cross-action absorbency mechanism, and that it pulls up bacteria and reduces the level of biofilm and all that stuff. So this is an example, a schematic drawing of one. So you can see it pulls up the biofilm, the bacteria, and the harmful matrix proteins, and it just pulls it up into that foam. And then when you take the dressing off, that's all gone. And then sort of a recently developed newer dressing is a hydroactive dressing. So this is a polyurethane matrix that's combined with the properties of gel and foam. So it's kind of like the best of both worlds. It absorbs excess water while leaving behind the growth factors and proteins needed to help heal the wound. And this is an example of a hydroactive. This is a kind of an all built in one mechanism where the cover dressing is built into the hydroactive foam part. And then I know that was a lot. There's a lot of different choices, and each category has multiple choices. So it's basically, like I said before, you have to use what's available. So, but essentially, this is sort of a breakdown of when to use what. The hydrogels we usually use during the debridement stage, so that helps pull things off of the wound. The foam and the low adherent dressings are for the granulation stage. The hydrocolloid dressings and with the low adherence dressings are for the epithelial stage. And then there's some advanced therapies that we're going to talk about in just a little bit. And then we're going to use antimicrobials as needed. So we do not use antibiotics or antimicrobials prophylactically in wounds, only if you have infections. So all wounds will be colonized because just by virtue of it being an open wound, it will be colonized with bacteria, but not all wounds are infected. So we only give antimicrobials when there is infection. There is no benefit to giving prophylactic antibiotics. And then some of the advanced therapies you may have seen, probably one of the most popular ones that's been around in the States for a long time or not a long time, but it's been around for a while, is the negative pressure wound therapy. So that's a vacuum assisted wound closure. It is continuous. It can be continuous or intermittent, and it is -50 to -175 millimeters of mercury subatmospheric pressure applied evenly to the wound surface. So essentially, you put foam, like a foam type substance, into the wound, and it's completely sealed with a tube that's connected to a machine. And I have a schematic drawing, and that machine just creates vacuum pressure onto the wound, and that the main thing that it does is it controls the exudate. That's like the number one thing. It increases the blood flow into the wound. It reduces the risk of infection, and it can be done at home. So they're portable, and you can use this as a bridge to surgical closure. So a lot of times we'll use this to get the wound clean and get it all ready, and the wound contracts a little bit, and then we can do a surgical closure, whether that's a skin graft or a flap closure or something like that. This is a schematic drawing of the negative pressure wound therapy. So you can see the black stuff in the middle, that's the foam, and the tube that's coming off the top, that's where the suction comes from, and it's connected to this little machine that's on the side there. Now they have big machines that we have in the hospital, and then they also have smaller ones that go like in a fanny pack or something like that, and patients go home with them. And you can see it creates a cell migration, proliferation of tissue, increases blood flow, and it controls all that exudate. So there's none of that bad fluid in the wound. And this is kind of what it looks like once it's on. So this is below someone's knee on the medial leg. And you can see the same thing, the black foam with this tube coming off the middle, the suction tube, that port that goes to the machine. Another sort of advanced therapy that's come around is this extracellular wound matrix allograft. So the human extracellular matrix is a structural component that surrounds the cells and binds the tissue. It's made up of collagen type 1, collagen type 3, and elastin and some other stuff. but those are the main components. And it acts as a scaffolding for the growth of tissues. So wounds that are slow to heal, sometimes we give them help by giving them an extracellular matrix allograft. So we can do partial or full thickness wounds. A lot of the first ones were made from porcine, neonatal foreskin, or amniotic membrane. And they can come in a powder or sheets or multiple layers. A lot of times they come like refrigerated and you have to reconstitute them. And then you can put them on the wound. You can do them in the office. They ultimately absorb into the wound bed. That you have to apply it every week. The downside is the cost. It's weekly application, but the cost is very expensive. And in the United States, it requires a lot of insurance approval and authorization and all this kind of stuff. But it does work tremendously well. And this is an example of an amniotic membrane allograft that's coming out of its packaging. So you take it out of there and you soak it in saline for a while. It becomes less pink, and then you put it onto the wound. And then oxygen therapies, which I'm sure you guys have learned about hyperbaric oxygen, but there's three main sort of routes for oxygen therapy. There's transdermal or continuous diffusion oxygen therapy. There's topical hyperbaric, and then there's hyperbaric oxygen therapy, which is the oldest and the most accepted form. So I'm only going to talk about the last one. So hyperbaric oxygen has been around since the 1600s. It's a systemic application of 5 to 7 days of a week for 90 minutes at a time, and you're delivering 100% oxygen delivered under increased atmospheric pressure, usually greater than 1 atmosphere, but up to 3 atmospheres, depending on how the patient tolerates it. The goal is to raise the oxygen level in the wound bed to correct the hypoxia in chronic wounds. So a lot of the inflammatory cytokines will inhibit oxygen in the wound. So this raises the O2 levels in the wounds. That helps with healing. So there are some complications, obviously. You can have middle ear trauma, middle ear effusions. You can have sinus barotrauma. You can have reversible myopia and seizures. This is kind of what it looks like. It's like a big giant tube that we put the patients in, and then it's like they're going scuba diving for an hour and a half. And then we bring them back out. And then this is another sort of advanced dressing, which is new to me. I have never used this type of dressing, but it's a bioelectric dressing. So it's a woven polyester fabric surface with a matrix of comparable silver and zinc dots. So they're 1 or 2 millimeters in diameter. So then you put a secondary moist dressing on top. It maintains the moisture level. And there's a microcurrent of like 0.6 to 0.7 volts that goes between these dots. And that's supposed to enhance wound healing. So that kind of looks like this. I've never used that one, but that was one of the newer dressings. And then for the future, like I mentioned before, there's a lot of studies going on right now with growth factors. So those are always coming up. And then stem cell therapy is also, there's some research in stem cell therapy for the future. And then as with every other aspect of medicine, gene therapy is sort of the new horizon. So that is on the future for wounds. And then I just want to thank you guys. This is my email if anyone has any questions. And thank you for the opportunity to share with you guys about wounds.
Thank you, Doctor.
You're welcome.
We appreciate your time. We know that your time zone is a little bit difficult, but we really appreciate your disposition. Now we are going to have a little time to answer the questions. We have Dr. Bruce Sands with us. So we are going to have a time to answer all the questions people have.
Okay.
So first question is for Dr. Sands. In addition to the excellently mentioned courses, what is the utility of the use of checklists for the care or, for example, the trauma patient? Your mic is off. You have to turn it on. Your mic. You have to turn it on.
Okay. Yeah. In terms of checklists are nice in trauma because a lot of things are going on while you're doing a trauma case. And sometimes the little things get missed, like the tetanus shot, or you may forget to hang the antibiotics if a person needs antibiotics. So by having a checklist, you go through that just to make sure everything was covered. You also do that in terms of, like, if you have two people doing the primary survey and you got someone that can record that, as I'm doing the primary survey, I'll call out what I'm seeing. And I'll say my negatives as well as my positive, and that person can write it down in terms of the primary survey. And then the secondary survey, when I'm doing a thorough exam, they'll write all those things down. And then you can just, you got everything documented, so you want to review everything, make sure everything was covered. And actually that kind of feedback usually comes at the time you're doing it. If you forget something, the other physician will say, hey, you forgot to check this or that. But checklists are just to make sure that everything gets done that you want to have done for the patient. You'd be surprised how many times certain labs will be admitted. We usually have trauma profiles. We would have trauma 1, trauma 2. Trauma 1 profiles would include a type and cross match, where the trauma 2 would just have a type and screen because there was no anticipated blood loss. But in case there was, you can quickly go from type blood to cross match blood, that type of thing.
Great, thank you, doctor. Do we have another question? If an emergency room hasn't the entire machine, what should we do?
So are you saying you're missing some of the equipment?
Yep.
What types of equipment? Are you saying you don't have access to a defibrillator, or
maybe any equipment is missing, or for local hospitals, which are really small?
Okay, so you may have an EKG machine, but not a defibrillator, that type of thing. So in a case like that, you would have to look at your monitor. If someone's in pre-fib, you couldn't shock them. So then you would have to do chest compressions. You would try using medication therapy to try to get them out of pre-fib. You use something like lidocaine. Do what you would do in ACLS if you tried to defibrillate somebody and it didn't work. So you would just have to try to use medication therapy. And if there's not perfusion, of course, chest compressions and ventilations, and try to get the patient back that way. You may not have pulse oximetry. Some of the things it's interesting. Some of the equipment is actually usable in your smartphone. Like I have a pulse oximeter that connects to my iPhone. So I just have that with me. So if I'm sometimes working in a clinic and they don't have a pulse oximetry, I'll use my own. It's relatively inexpensive at $100. You just plug it into your iPhone, or it also works in the Androids as well.
Okay, let's see if we have another question. The ABCDE method used for trauma patients only?
Yes, it's basically used for trauma because your airway, breathing, circulation, disability, and you undress the patient. So in a lot of medical cases, you won't need to do that. And remember, it used to be for ACLS, it was airway, breathing, circulation. Now it's circulation and airway, breathing. So we've gone in ACLS from ABC to CAB. We immediately check for circulation. If there's no pulse, you start doing compressions. You ventilate after 2 minutes. And if you don't have a monitor, then you just keep doing that until you either get a response or you declare a patient dead after a time frame that's pre-established.
Thank you. Can you start an ACLS protocol in a outpatient clinic?
Sure. If you have the resources, say if you don't have a monitor and things like that, then you would do basically basic life support. If you have drugs, you can use some of those if you have them available. But ideally, you want to use them in conjunction with a monitor to see what you have. In terms of
Great. As emergency specialists, are you leading all those teams or they are already confirmed as a protocol?
Well, we have protocols, but like in the level 2s I work at, the physician is running the trauma team. Sometimes if we have a surgeon, because all surgeons in the United States who are on hospital staffs, at least to my knowledge, have to do the ATLS course. But what would happen is most of the time is they're at home, we would initially see the patient and we would call them and they would come in. But until they get there, we would manage the trauma until they get there. And in some cases, they would just manage the case through us if it was something that didn't need surgery, didn't appear to need surgery, then a lot of times they wouldn't come in right away. And I would work up the patient, admit them, and they would see them in the morning if their injuries didn't warrant an immediate evaluation. But the protocols are just there to help you and guide you. And they're pretty standard. It's like in terms of how you proceed, but they're not set in stone.
Okay, thank you. Do we have another question? We have this question for Dr. Marcus. Do you think management of some wounds should be reconsidered according to the pandemic, like trying to continue management like outpatient rather than hospitalized? If it's so, how and when should we do it?
Okay, yeah. So most wounds are managed outpatient. I mean, in the U.S. at least, except for when they have to be debrided in the OR and those kind of things. But I would say the majority of wounds are managed outpatient. Most people that are going to have these wounds are going to have lots of other medical conditions. So keeping them out of the public is probably going to be the best. And then admitting them to the hospital when they absolutely have to be admitted for like a really bad cellulitis or infection or some other medical problem. But I know here in the U.S., home health nurses are going to homes. They're taking care of wounds in the homes. They're, things are, as far as that goes, are relatively normal. But I would say majority of patients are going to be manage outpatient right now. I can't hear you. But what is the main use of skin graft?
What is the main use of skin grafting currently, and which patients benefit the most?
Okay, well, skin grafts are used for a lot of the different things. Probably majority of burn patients that are admitted to the hospital that have significant burns are going to be requiring lots of skin grafts. In like wounds, like we see, like not burn wounds, but wounds that we do outpatient stuff, like on the legs and, you know, venous stasis ulcers and stuff, we do use skin grafting. Normally what we do is we use all the other modalities to get the wound clean, to get the everything under control, good granulation tissue, you know, a good smooth skin bed. And then once that's all set and you kind of get to the point where you're not getting a lot of advancement with epithelialization, then you can consider a skin graft. But the main use, I would say, for wounds is going to be in reference to burns, because they have a lot of skin grafts where they to cover up those wounds as fast as they can.
I have a question in the very first part. In the wound, if the wound is so deep in the remodeling phase, it will make a different type of skin resulted from the type 1 collagen, right? Is this how scar formed?
Well, the wound, like if it's a deep wound, so just say if it's like a V like this, so as the wound heals, it's going to fill in from the bottom and it's going to contract on the top. So it contracts and it fills in, and then when those two meet is when you have closure, or the scar. And the scar, once in the remodeling phase, all the type 1 collagen is what's the type 3 is converted to type 1, and then that's basically how the scar is formed. You're correct, but the remodeling phase, after it's all healed, then the body will smooth that out, and you know, sometimes over a year it takes. It'll not look what it's going to look on the final, you know, what it's going to look like forever, until usually about 8 months to a year, because it'll smooth out a little bit. It'll get a bit softer, won't be as firm, and that's the body sort of remodeling that and converting the type 1 collagen and getting it to where it's as best as it can be.
When do you consider to use skin transplant as the management of a deep wound?
I would not use a skin transplant as a management of a deep wound. So deep wounds, you want them to fill in. So that's where deeper wounds, we would use the vac dressing or the vacuum assisted dressing, the negative pressure dressings, to fill that in. And then if it's still pretty deep, depending on where it is, you can use a flap closure. So that would be like either a muscle, subcutaneous tissue and skin, or subcutaneous tissue and skin with blood vessels that can close up that area, like on a decubitus ulcer or a sacral ulcer. That's where we would do that. But the wound has to be pristine. It has to be clean, no exudate, no inflammation, good granulation tissue, and then that's when you would do that sort of like flap closure. When you say skin transplant, I'm assuming you mean skin graft. So for deep wounds, we don't use skin grafts. So it would only be for shallow wounds, covering up wounds that have almost healed but not completely, but they're more flat.
In cases of tension pneumothorax and the patient is really hyperventilated, and you consider intubation, what should be done first? The thoracostomy or tracheal intubation? We can't hear you, Bruce. Your mic's off.
Okay. Once you've got a tension pneumothorax, you've got pressure buildup on that side. So you wouldn't want to intubate them. So what you would do is rapidly put in a large catheter to convert that tension pneumothorax to a simple pneumothorax. Then you would intubate, then you put in the chest tube. If they're in that much distress. A lot of times, if there's someone there that could bag the patient, what I would do is I would convert that tension to a simple pneumothorax, and I would immediately put in a chest tube and have someone bag the patient while I'm doing that. Just keep in mind, once you do a positive pressure ventilation on a patient, you're gonna want to build up more pressure in that pleural space through that leak. So wherever that leak is, it's going to want to leak out through there. So you're going to need to put in a bigger tube as soon as possible. So I would like do one right behind the other.
Okay. I think that's it. So we really appreciate both of you. We again apologize for the inconvenience, and we hope everyone enjoyed. Thank you very much for your assistance. Remember to fill out the attendance certificate that you will find in the description box and in the broadcast chat. It will be available for only 1 hour. After that time, the form will not be reopened under any circumstances. And please join us on Thursday at the same time for our second day of talks. Have a good evening, everyone. Thank you.
Thank you.
Hola, soy Saura Gallego Ojeda, directora ejecutiva de Asesores Gallego Ojeda. Somos una empresa dedicada a la homologación de títulos universitarios, con sede principal en España. Nacimos por la creencia de que todos los profesionales se sienten orgullosos de su profesión y la enaltecen día a día con cada uno de sus actos. Por eso, creemos que si cada profesional quiere crecer, tanto académica como profesionalmente, debe tener la posibilidad de hacerlo. En Asesores Gallego Ojeda abrimos la puerta a todos los profesionales que quieran dar un paso adelante, que quieran crecer, que quieran vivir, que quieran explorar. Nosotros tenemos las herramientas para que todo eso sea posible. Nosotros nos acomodamos a las necesidades y los retos que nuestros profesionales nos imponen. Nosotros te demostramos que sí es posible.
Hola, soy Uriel Juanes, gerente de Asesores Gallego Ojeda. Homologar tu título es muy sencillo y te lo voy a explicar en 3 cómodos pasos. Primero, obviamente, contáctanos a nosotros. Segundo, documentos necesarios. Debes saber que somos una empresa pro medio ambiente y todos los documentos van a ser digitalizados. Documentos que tienes que aportar: pasaporte, calificaciones y diploma. Y en caso de que sea necesario, certificados laborales y pensum académico. Y tercer paso, haz tus maletas y espera nuestra notificación de que ya tienes tu credencial de homologación.
Es fácil, sencillo. Asesores Gallego Ojeda, tu mano amiga.
Marta es uno de los tuyos. Es estudiante del MIR. Se esfuerza en todo momento para superarse, como tú. Repasa sus marcas a cada paso, pero no estudia como tú. Porque Marta es pro-MIR. Ha encontrado un método. Su método.
Buenos días, Marta. Hoy entrenaremos valvulopatías. Actualmente has alcanzado el 60% de la nota máxima en esta asignatura, un 10% superior al resto de los aspirantes. Si alcanzamos el 80%, podría suponer entre 5 y 7 puntos en el MIR y habrás superado tu nota objetivo.
ProMIR ha desarrollado el entrenamiento que se ajusta a Marta. Analiza sus fortalezas y debilidades, se adapta a sus objetivos, optimiza sus esfuerzos, muestra la evolución de sus resultados para que Marta tenga claro que alcanzará la plaza que quiere. Hemos volcado 60 años de experiencia en Promir y ahora es su centro de alto rendimiento. Por eso Marta es Promir. ¿Eres tú, Promir?